In almost every area of medicine, catching a problem early and, hitting it hard is basically the gold standard.
Right. We're explicitly taught to be proactive.
Exactly. But today, we are looking at a scenario where your proactive hit it hard instinct might actually cause a pretty catastrophic bleed.
Yeah, it's a massive pitfall.
Picture this. You are on the ward managing an adult patient with an uncomplicated parapneumonic effusion. You've done like everything by the book.
Mm-hmm. The chest tube is successfully placed.
Right. The tube is in, you have fluid actively draining, and the appropriate broad-spectrum antibiotics are running. The patient is currently stable.
Which is great. That's what you want.
Exactly. But as you are reviewing the chart on day 2 or, day 3, that lingering question creeps in.
It always does.
You look at the drainage output, which is starting to look a little sluggish, and you wonder if you should add intrapleural fibrinolytic therapy.
Like TP?
Right, like TPA.
Mm-hmm.
Will pushing a lytic agent down that tube speed up the resolution? Will it clear out that pleural space faster, re-expand the lung, and get this patient home sooner?
It is one of the most common and, frankly, one of the most tempting clinical gray areas you will face in respiratory and critical care medicine.
Oh, absolutely.
The instinct to escalate, to add just one more intervention to accelerate healing, is incredibly strong when you are staring at a daily chest radiograph that just isn't clearing as fast as you would like.
Right, you want to see progress.
Exactly. So we are unpacking the specific clinical dilemma to map out exactly when to use fibrinolytics in these presentations, and crucially, when you need to step back and avoid them entirely.
Because in the world of uncomplicated effusions, more intervention does not automatically equal better care.
No, it really doesn't.
Okay, let's unpack this. We need to look at why that temptation to intervene exists in the first place.
Well, it's human nature, really.
Yeah, you have a patient in the bed, and there are pharmacological agents, like tissue plasminogen activator, designed specifically to break down barriers in the pleural space.
Right.
It feels almost counterintuitive to leave them sitting in the pharmacy. I mean, you want the fluid gone and the lung fully re-expanded.
Of course you do. But the standard of care for these uncomplicated parapneumonic effusions is actually highly conservative.
Just antibiotics and chest tube drainage alone.
Exactly. We rely on that standard approach because it leverages the body's natural physiological recovery mechanisms without introducing heavy-duty pharmacological risks.
Makes sense.
To understand why we hold off on fibrinolytics, we really have to look closely at what is actually happening at a cellular level in an uncomplicated effusion.
Right, the actual pathophysiology.
Yeah. At this stage, you are dealing with an inflammatory cascade. The bacterial pneumonia adjacent to the pleura has caused the mesothelial cells lining the pleural space to release inflammatory cytokines.
Which increases capillary permeability.
You got it. You get a protein-rich exudative fluid leaking into the space. But importantly, the fluid is still free-flowing.
So the physiological target hasn't changed yet.
Right.
Think of the pleural space like a flooded basement. The chest tube is your sump pump, and the antibiotics are, fixing the burst pipe and killing the mold.
That's a great way to visualize it.
Right. As long as the water can physically reach the pump, the basement will drain. Fibrinolytics. That is taking a sledgehammer to the basement walls.
Yeah, and you don't swing a heavy sledgehammer unless there are actually physical walls blocking the water from reaching your pump.
Exactly.
If we connect this to the bigger picture, it explains exactly why our clinical posture in these early uncomplicated cases must remain conservative.
Because those physical walls aren't there yet.
Right. The walls, in your analogy, are fibrinous septations and loculations. In a complicated effusion, the inflammatory environment becomes highly procoagulant.
Tissue factors expressed.
Yes, and the local fibrinolytic activity is severely depressed due to an upregulation of plasminogen activator inhibitor 1, or PAI1.
Ah, okay.
So fibrin starts depositing in thick webs, creating isolated pockets of fluid. Fibrinolytics are designed to attack those specific fibrin webs.
But in an uncomplicated effusion, those webs just do not exist yet.
No, they don't. You are basically swinging a sledgehammer in an empty room.
You are deploying a highly targeted weapon into an environment where the target simply isn't there.
Yeah.
And you're taking on all the collateral damage with zero tactical advantage.
Precisely. And the clinical outcomes reflect this biological reality.
Yeah, adding fibrinolytics to an uncomplicated parapneumonic effusion does not consistently improve resolution rates or shorten hospital stays.
You are not getting the patient home any faster by adding this therapy up front.
Right.
The negative pressure from the chest tube, combined with the antibiotics halting the inflammatory cascades so the pleural capillaries can stop leaking and start reabsorbing, is entirely sufficient for the vast majority of these patients.
So maintaining a low confidence level in the routine use of fibrinolytics here is really just respecting the pathology of the disease state.
Exactly.
But wait, if a patient is just hovering, not getting worse, but not miraculously better overnight, I can see the temptation to try a low dose just to see if it helps.
Sure, it's tempting.
Let's say it's day 3. The chest tube output is definitely sluggish. What's the real danger in just trying a tiny bit of TPA?
This raises an important question. It feels like a calculated gamble, but you are playing at a casino where the odds are entirely rigged against you.
Oh, wow.
Yeah, there is no small dose safety net in the adult data. The real danger is that there is absolutely no validated dosing or timing regimen for fibrinolytics in uncomplicated adult cases.
So you are essentially guessing with a high-risk medication.
You are stepping way outside the evidence base, and the penalty for guessing wrong is severe.
Right, because if we know the sledgehammer isn't actually clearing the fluid any faster, we have to look at what it is doing while it just sits in the pleural space.
Which is the mechanism of iatrogenic harm. The major risk factor you are introducing is bleeding and profound coagulopathy.
Because of how these agents work.
Yes. They convert plasminogen into plasmin. Plasmin is a highly aggressive enzyme that cleaves fibrin into degradation products.
But plasmin is not entirely selective.
Not at all. When you instill TPA or urokinase into the pleural space, it doesn't just look for floating fibrin webs, it actively strips the pleural space of its natural clotting ability.
And you just placed a large bore, rigid plastic tube directly into that highly vascular, inflamed space.
Exactly. The chest tube insertion site relies on a local hemostatic plug, a fibrin clot, to prevent bleeding from the intercostal vessels and the traumatized parietal pleura.
Right.
Furthermore, the inflamed pleura is undergoing neovascularization. It is raw and friable.
So when you flood that space with a potent fibrinolytic, you dissolve the protective clots along the tube track and across the inflamed pleura.
You expose the patient to the risk of a catastrophic intrapleural bleed, creating a hemothorax on top of a parapneumonic effusion for essentially zero upside.
That balance of risk and reward is completely skewed against intervention.
Completely.
And it brings up a huge trap that clinicians often fall into when trying to justify that intervention, which is extrapolating data from other patient populations.
We see this all the time with pediatric protocols.
Yes. Clinicians will look at a pediatric algorithm that uses fibrinolytics early and try to map it onto an adult.
But the physiology, the disease progression, and the risk profiles simply do not map over cleanly.
They're totally different.
Right. Pediatric parapneumonic effusions are often driven by different pathogens, frequently Streptococcus pneumonia. And children have incredibly robust, compliant lungs without the decades of structural changes, smoking history, or comorbidities we see in adults.
So their baseline bleeding risks are entirely different.
Night and day.
An adult patient might be on antiplatelets, they might have subtle uremia affecting platelet function, or they might just have a stiffer lung compliance that changes how the pleural space dynamics operate.
Exactly.
Taking a protocol designed for a generally healthy 6-year-old with a pneumococcal effusion and applying it to a 60-year-old with diabetes and COPD is a really dangerous game.
It is entirely unvalidated. And while we are addressing the urge to intervene, we need to dismantle a few persistent clinical myths that fuel this prescribing mentality.
Oh, definitely. Like the lingering belief on the wards that throwing fibrinolytics early at an uncomplicated effusion might somehow stave off long-term damage, prevent pleural thickening, or ultimately save the patient's life.
Right, but the data simply does not support that narrative. Fibrinolytics do not improve mortality in uncomplicated cases.
Not at all.
They also do not improve long-term lung function. You aren't preserving vital capacity 6 months down the line by pushing TPA on day 2.
So you have no mortality benefit, no long-term lung function benefit, no consistent reduction in length of stay, no validated adult dosing, and a wildly unpredictable bleeding risk.
When you stack the clinical realities up like that, the temptation to just try it really starts to look less like proactive medicine and more like reckless guessing.
Yeah, the standard of care, antibiotics, and chest tube drainage alone is the standard for a reason.
It is highly effective at managing the pathology that actually exists in that moment, and it limits unnecessary harm.
So you must establish a firm baseline rule. Do not routinely apply fibrinolytics in adult uncomplicated effusions.
Absolutely.
Here's where it gets really interesting, though. Clinical medicine is never static.
No, it's constantly changing.
We aren't just placing a chest tube, starting antibiotics, and ignoring the patient for a week. The default approach we are advocating for isn't passive.
Right. It is highly active monitoring.
We are watching the patient's clinical trajectory closely because the math does change. There are specific moments, dynamic shifts in the patient's presentation where you absolutely should reach for those fibrinolytics.
This is the critical transition in patient management. You maintain your conservative posture, but you keep your hand hovering over the escalation button.
You are actively looking for the physiological signals that tell you the effusion has fundamentally changed its character.
You are waiting for the pathology to match the pharmacology.
So let's look at what that active monitoring actually looks like by walking through a patient's progression.
Sure.
Let's say it is day 4. The patient has been on standard therapy, but things are stalling. You decide to do a follow-up bedside ultrasound.
A very smart move.
Suddenly you look at the screen and you see those echogenic, cobweb-like structures starting to form within the fluid.
Yeah.
You are seeing loculations and fibrinous septations.
What's fascinating here is that the target has officially arrived. The effusion is no longer uncomplicated. The inflammatory cascade has progressed. The PII-1 levels have overwhelmed the local fibrinolysis, and those physical fibrin walls have been built.
So the fluid is now sequestered in pockets that your chest tube simply cannot reach.
Exactly. The mechanism of the fibrinolytic drug now perfectly aligns with the pathology of the patient.
You use the drug to break down those septations, turning a multi-loculated space back into a single communicating cavity that can actually drain.
The structural barriers have formed, so now you bring in the sledgehammer.
But what about the clinical presentation? I mean, you aren't just treating the ultrasound screen. You are treating the patient, and sometimes the clinical signs declare themselves before the imaging does.
Very true. If the patient is failing to improve or actively worsening despite having appropriate broad-spectrum antibiotics and standard drainage in place, you have a major pivot point.
Like if the patient is still spiking fevers.
Yes. Or their white count is climbing. Their inflammatory markers like CRP or procalcitonin are trending up instead of down.
Or perhaps you notice the fluid is reaccumulating on the daily radiograph despite a patent chest tube.
That's a classic sign. You have a failure of your standard therapy.
The sump pump is running, but the water level is rising.
When you see that clinical deterioration, you must immediately reassess for complicated features.
Right.
This is the moment to image again, often with a contrast-enhanced CT of the chest, to look for those septations, pleural thickening, or a split pleuris sign.
The failure to improve is your red flag that the conservative approach has reached the limits of its efficacy.
Exactly. And you need to seriously consider escalating to intrapleural fibrinolytics, often in combination with DNAs to reduce fluid viscosity, or initiating a surgical referral.
And that brings us to the surgical context, which is a very specific clinical needle to thread.
It really is.
Let's say you get that CT scan. The effusion is heavily loculated. It has evolved into a complex, multi-septated collection, maybe even an early empyema. We know they need intervention. Normally, the definitive treatment here might be surgical decortication.
But decortication is a major procedure. The thoracic surgeons have to go in, often via video-assisted thoracoscopic surgery or an open thoracotomy, and physically peel that thick, fibrous rind right off the visceral pleura to allow the trapped lung to re-expand.
Right. It is highly effective, but it places a massive physiological stress on the patient.
A huge stress.
So what if your patient is a poor surgical candidate? What if this is an 80-year-old with severe COPD, heart failure, and a frailty score that makes the surgeons incredibly hesitant to take them to the operating room?
Well, when we look at the data confidently, fibrinolytics reduce the need for surgical intervention, mainly in complicated parapneumonic effusions.
Okay.
That is their primary proven triumph. So if you have a patient whose effusion has complicated, but their comorbidities make them an incredibly high risk for surgical decortication, fibrinolytics become a vital, less invasive alternative.
You are using the chemical approach to avoid the surgical trauma.
Yes. You use them cautiously, but you use them out of absolute necessity.
It is the crucial middle ground between a chest tube that isn't working and a surgery the patient might not survive.
Exactly. But we must attach a strict caveat to this, however.
Always caveats.
Always. You should never use fibrinolytics as a casual substitute for surgery without incredibly careful multidisciplinary consideration.
Especially in fully loculated effusions with a thick pleural rind.
Right. Fibrinolytics are a tool, not a magic wand. If the patient is a viable, robust surgical candidate and the effusion is heavily loculated, surgical intervention often remains the most definitive and appropriate treatment to achieve full lung expansion and source control.
Fibrinolytics shouldn't just be a stall tactic that delays definitive surgical care when surgery is clearly the right answer.
Definitely not.
And it goes without saying, but in the reality of ward management, it always bears repeating. Even when you hit one of these pivot points, even if the ultrasound shows massive loculations or the patient is failing to improve.
If they have active coagulopathy or major bleeding risk factors, the balance tips right back against fibrinolytics.
Because the bleeding risk doesn't magically disappear just because the effusion got complicated.
No, it doesn't. If the patient has a low platelet count, if they are on therapeutic anticoagulation that cannot be paused, or if they have recent trauma or surgery, you have to respect those contraindications.
The harm potential of a massive, life-threatening pleural hemorrhage vastly outweighs the benefit of clearing a loculation pharmacologically.
In those highly complex scenarios, you are leaning much more heavily towards surgical intervention, interventional radiology guided placement of additional targeted drains, or modifying your existing drainage strategy rather than risking a catastrophic chemical bleed.
It requires a delicate, highly individualized assessment.
It does. But the core principle remains. You only introduce the risk of the fibrinolytic when the pathology absolutely demands it, and the surgical alternatives are either inappropriate or unacceptably high risk.
So what does this all mean? We have journeyed from that initial, very human temptation at the bedside, deeply explored the cellular and physiological reasons why standard therapy works, examined the dangerous mechanisms behind unvalidated dosing and bleeding risks, and finally walked through the specific patient presentations where our strategy must dynamically shift.
It means we can synthesize a very clear, actionable posture for the clinician. Managing these patients requires absolute confidence in the basics and deliberate, evidence-based restraint with your more complex tools.
Let's lock in the one clear rule for your clinical toolkit today.
In adult uncomplicated parapneumonic effusions, you manage the patient with appropriate broad-spectrum antibiotics and chest tube drainage alone.
Right. You must reserve your fibrinolytics only for those cases that show evolving complicated features on imaging, patients who demonstrably fail to improve on standard therapy, or those with complicated effusions who have absolute contraindications to surgery.
And through every single step of that decision tree, you are continuously and carefully weighing their bleeding risks.
That framework keeps your patients safe from unnecessary, purely iatrogenic harm.
It respects the actual biological mechanisms of both the disease state and the therapies we possess, and it provides clear, rational boundaries for when to escalate care.
You default to no fibrinolytics up front, you monitor clinical progress and imaging closely, and you escalate only when the physiological target presents itself.
That's the takeaway.
As you head back to the wards, I want to leave you with a final, slightly provocative thought regarding medical culture. As clinicians, we are deeply, fundamentally conditioned to intervene.
We really are.
When a patient is sick, when they're lying in that bed and not getting better fast enough to satisfy our expectations, the internal pressure to do something more is just immense. It feels productive to write an order. It feels passive to wait.
But we have to step back and ask ourselves,
Exactly. How often does our own clinical impatience blind us to the elegance of letting a standard low-risk therapy just do its job? When you are standing at the workstation holding the order for a powerful anxiolytic agent on a perfectly uncomplicated case, ask yourself, are you truly treating the patient's effusion, or are you just treating your own anxiety to see faster results on the chart?